Hello, everyone, and welcome to our presentation today, where we will discuss one of the most pressing factors affecting HIV vulnerability, stigma. In our presentation titled Building Capacity and Mobilizing Value-Guided Community Action to Reduce HIV Stigma, we will share about Project ACE. Before we begin, we would like to acknowledge the land from which we speak and work. We acknowledge that we are on traditional territories of the many First Nations, Métis, and Inuit, and now known as Alberta, and express gratitude and respect for the land we use. We commit to reducing stigma and racism while partnering with others in advancing reconciliation. We are grateful to all whose footsteps have marked these lands for centuries before us. Additionally, as we reside on the traditional territory of the Anishinaabe, Haudenosaunee, and Wendat peoples, we are reminded of the long-standing commitment to the protection of these lands by those who came before us. As settlers, we acknowledge and honor the great contributions of all First Nations, Métis, and Inuit peoples, and recognize our responsibility in furthering reconciliation and engaging in meaningful actions towards justice and equity. We would also like to take this time to acknowledge the many people who have come together to make this project happen. Thank you to our 93 Phase 1 participants, community collaborators, staff and trainee team, research team, our project advisory committee, graphic designer, and funders from the CIHR project grant. For today, we will be going over the session objectives, give a project background, ACE model, and Project ACE, followed by discussing Phase 1 results and concluding with the learning and mobilization strategies employed in Phase 2 and 3 of this project to reduce stigma and build community resilience. This session will allow you to identify essential aspects of inclusive HIV literacy and effective stigma reduction, identify how key processes of the ACE intervention addresses internalized and enacted HIV stigma, and articulate cross-sector strategies for HIV stigma reduction and collective empowerment. To discuss the backdrop of literature that is informing this work, we look to Canada's demographic landscape, which shows that nearly 1 in 5 individuals is an immigrant, with approximately 70% of these immigrants belonging to racialized groups. Racialized immigrants thus experience a disproportionately high burden of HIV, and analysis of population data substantiates this, highlighting significant impacts on these communities. In 2019, 42.7% of reported HIV cases included race or ethnicity information. However, currently, over 50% of HIV data still lacks this crucial information due to resistance from some provinces to collect this data, despite ongoing advocacy efforts. This underscores that while racialized individuals make up a minority of the population in Canada, they represent a significant proportion of HIV cases. Research such as the We Speak project led by Josephine Wong and her team has demonstrated through mixed methods approaches that the vulnerabilities of heterosexual Black men to HIV are predominantly linked to structural factors rather than individual behavior. Critical factors include access to primary care, inclusive and safe information, and the ability to safely seek HIV-related information. Additionally, structural determinants such as income, racism, and racial stereotypes further exacerbate their vulnerability to HIV. These intersecting marginalizations mean that our priority populations face multiple forms of oppression, including racism, sexism, homophobia, transphobia, inadequate housing, poverty, and HIV-related stigma and discrimination. And these interconnected oppressions collectively contribute to the heightened vulnerability of racialized immigrant populations in Canada. Now, we invite you to watch a video on the background of Project ACE.
Welcome to our Project ACE online training module. To start our exciting learning journey together, let us first share with you some background of ACE and how this training came about. ACE training, which stands for Acceptance Commitment to Empowerment Training, is a community-based and evidence-informed intervention originated from the CEM Research Project done by the Committee for Accessible AIDS Treatment in 2011 to 2015. The CEM research was led by CAT, the Committee for Accessible AIDS Treatment, and conducted in partnership with 4 other ethno-racial AIDS service organizations: ACAS, Asian Community AIDS Services; ASAP, Alliance for South Asian AIDS Prevention; BlackCap, Black Coalition for AIDS Prevention; CSSP, Center for Spanish-Speaking Peoples; and APA, African in Partnerships Against AIDS, along with different researchers from the health and academic institutions, including the University Health Network, Ryerson University, now renamed as the Toronto Metropolitan University, and the University of Toronto. Here is a complete list of our original CEM research study team. We developed the CEM study because we knew that HIV stigma is a powerful force that undermines our efforts in preventing HIV and create huge barriers for people with HIV to access treatment and support. And for racialized communities, we are especially impacted as a result of the additional intersecting discriminations we experience due to racism, homophobia, and xenophobia from the mainstream society. CEM was our community's collective effort to try to find effective interventions to reduce HIV stigma and tackle these intersecting oppressions. Specifically, the purpose of the CEM research study was to pilot and evaluate the effectiveness of 2 interventions in reducing HIV stigma and developing HIV champions in the Caribbean, African, Asian, and Latino communities in the Greater Toronto Area. The 2 interventions are Acceptance and Commitment Training, or ACT Act, and Social Justice Capacity Building, SJCB. Overall, our training model, which now we call ACE for Acceptance, Commitment to Empowerment, integrates the ACT and SJCB components. To give us an overview, the Acceptance Commitment Training component aims at promoting health through developing skills that increase psychological flexibility. The Social Justice Capacity Building component promotes understanding of systemic oppressions and facilitates skills in building individual resilience and mobilizing collective action. We will explain this integrated model in more detail in our next online training session. For this study, we engaged people living with HIV and non-people living with HIV community leaders from faith-based, media, and social justice sectors in the Asian, Black, and Latino communities in the Greater Toronto Area to participate in the study. Based on the research data which followed participants' activities for 9 months after the training, we found that the people living with HIV participants show that they have reduced internalized self-stigma, and the non-PHA participants have reduced stigma against HIV/AIDS. All participants show that they have increased taking action aligned with their values and increased taking action to challenge HIV stigma and promote social justice. Following the success of the CEM study, our community agency partners successfully applied for 5 years of program funding from the Public Health Agency of Canada to implement this intervention in our communities. Before the COVID pandemic, this training was conducted all in person over 4 full days. In response to the physical distancing initiative of the pandemic, we have adapted the CEM training for a combined online self-learning and video group session-based training. The proven effectiveness of the ACE training model has since inspired different adaptations for application in addressing different health and social issues. Examples include the National Strength and Unity Project that tackle mental health stigma amongst Asian men in Canada, the Transnational ACE Training Project that addresses mental health stigma for university students in China, and the PACER online program developed during the COVID-19 pandemic to address mental health impact amongst professional health service providers and community caregivers. So now we are excited to welcome you on board to join our Project ACE family and become our next generation of HIV and social justice champions. Let our journey begins.
So the following slides talks about our phase 1 result. Phase 1, it's all about contextual assessment. In the service provider survey, our goal was to understand their perspectives on community needs specific to HIV stigma. We sought to identify both the facilitators and the barriers to reducing stigma and to pinpoint the stigma-related issues that need to be addressed. From our community members' perspective, we wanted to learn about their experiences on HIV stigma, as well as their strategies for resistance and examples of community resilience they have experienced or observed. So the organizational baseline survey, as I have already explained, aimed to gather information about the current stigma reduction programs and services, as well as the client population that they serve. The phase 1 baseline survey, in this data, we were able to work with 18 organizations for our baseline survey. So with a variety of services they provided, we found out that 4 of them provided the primary care services, while 2 provides legal services. Mental health are the 7 of them. We have 10 of them providing social services, while we also have 12 providing sexual health services. 4 were in settlement, and 7 in addiction services. 10 were providers of peer support services, and 7 were uncategorized. However, we did not have any faith-based organizations at the time. So it is important to note that many organizations provide multiple services, which is why the total number of our providers exceeded 18. Regarding service outreach, 13 out of the 18 organizations serve over 1,000 population annually. So in the past month, 17 of these organizations have provided services to racialized community and immigrants and or refugees that account about 50%. Their users were 50% racialized immigrants or refugees. So when asked whether they provided services to people living with HIV, 10 of these organizations confirmed that they did, while 2 of them answered that they did not, and 6 were unsure at the time. However, their uncertainty often stems from workers in settlement or other social services not specific to HIV, who might have not known the HIV status of their clients. So in qualitative focus groups, some service providers express uncertainty about how to address HIV-related issues, despite recognizing their importance. So many clients first engage with settlement services, making these providers potentially crucial in disseminating HIV information. However, these providers often feel unprepared due to a lack of knowledge about HIV. So in the phase 1 focus group participants, when we combine all community members and service provider leaders that we have encountered, we had a total of 93 participants. Participation was evenly distributed across various sites through Alberta and Ontario. However, London had a larger group, as you can see, with 21.2%. due to the nature of the work being done and our coordinators' extensive connections. As you can see as well, Edmonton also have similar number. HIV stigma emerged as a significant issue consistent with findings from one of our previous studies. Now, regarding the ethnocultural identity, many participants were from African Caribbean Black community, as you can see in this slide. This is noteworthy as ACB communities are disproportionately affected by HIV. Additionally, we also notice the Latin American and some Middle Eastern communities are also impacted. However, these communities in Toronto, they remain relatively silent. While there is increasing participation and identification of needs, they are not yet organized or recognized enough to engage fully in activities. When we look at the sexual orientation, about 73% of the participants identified as heterosexual. We also had representation from the bisexual community and also those who are still questioning their sexuality. Though, these categories, they were not explicitly listed. However, the gay population accounted for approximately 7% of the participants. So in terms of gender identity, on my right-hand side, more women participated, which is very common in health and social research, where women tend to have a higher rate of participation. So this slide in front of us here shows a diagram that was developed in 2016. Interestingly, our phase 1 data from 6 cities across Ontario and Alberta indicates that the same issues still persist. Participants report that religious discourses and the moralistic discourses continue to reinforce stigma, which is prevalent in all of these communities. Racialized communities are still dealing with myths that reinforce harmful discourses, such as homophobia, transphobia, and blame. This creates a significant fear of being stigmatized, not just for HIV, but also racially. There is also discussion about the stereotypes and racist discourses surrounding the origin of HIV. These factors discourage community members from discussing HIV matters, as they already face racism and now have to contend with stigmatizing racial stereotypes about HIV. Consequently, we also see that people often avoid accessing services due to fear and shame. This stigma and discrimination totally contribute to interpersonal violence among participants. So gender-based violence is also of a concern, particularly when HIV status is disclosed. This in turn creates an unsafe environment that prevents people from seeking services and support. The invisibility of HIV within the community kind of leads to a misconception that no one is affected. This further is perpetuating the issue of HIV infection spreading in the community. Participants who immigrated to Canada noticed the lack of visible HIV information, leading them to believe that HIV is no longer an issue in Canada. This silence and the invisibility further perpetuate infections. During the CAR conference in London, Ontario, community workers highlighted that many people living with HIV are now also experiencing cancer. Yet, this topic remains silent and unaddressed. So the emotional disconnection caused by this invisibility dehumanizes HIV as a condition. So participants often note a lack of understanding about undetectable equals untransmittable. The popular U equals U, particularly the communities directly affected by HIV. So interactions within this community, however, impacts everyone. On the right side of this slide is information from a recent study conducted across Canada and globally, the Stigma Index study. This study found that internalized stigma significantly affects how people rate their own health versus how they determine what is poor health. So there is a strong correlation between poor health ratings, and the actual poor health. So stigma is also reinforcing mental health challenges such as depression. So here is a preliminary result from the focus group that was conducted across all our 6 sites. The preliminary result from this focus group highlights several key issues. HIV stigma has been identified as severely impacting mental health, often leading to substance use. And this is a key issue. Talking about the mental health issue among people living with HIV. So HIV stigma has been identified and is severely impacting mental health of people, often leading to substance use as a coping mechanism, which in turn increases HIV vulnerability. Historical and ongoing systemic racism intertwined with HIV stigma creates a significant barrier to accessing services like HIV prevention and care. So this stigma is both internalized and also experienced externally. Structural violence against women is also something that was highlighted as a significant issue. With women's experiences differing significantly from men, the LGBTQ community also face additional stigma and marginalization, which further increases their HIV vulnerability. Participants noted the lack of HIV literacy among the general public, which perpetuate stigma consistently. Now, while people living with HIV understand their treatment and care and all of this knowledge, they found that this knowledge is not widespread, affecting their ability to work and form relationships. So it was noted that there is insufficient public understanding of that concept, U equals U. That is, undetectable equals untransmittable. And the pre-exposure prophylaxis, PrEP. So information campaigns often do not reach the systematically marginalized communities. We also found that racialized communities stress the need for resources beyond the HIV sector. This stresses needs including things like housing, employment, education, and healthcare. So finally, on this note, we found that community engagement was identified as crucial for reducing stigma and promoting resilience, echoing the sentiments of many participants. So when we send out flyers to recruit service providers and community leaders, we actually aimed for 30 participants, but successfully recruited 32 participants. So on the left-hand side of this slide, you can see organizations focusing on addiction and settlement services. These groups have done very little to reduce HIV stigma. However, through our social demographic forums, we discovered that many participants, despite identifying as community members, also they double as service providers, such as peer support workers or counselors. So this dual role significantly has increased HIV stigma reduction efforts, highlighting the crucial impact of peer roles. So this dynamic, we found that it aligns closely with the goals of our project, Project ACE, emphasizing the importance of community-driven strategies. So in summary, our findings suggest that HIV responses must address systemic racism, gender-based inequalities, and related oppressions, as well as sexuality and citizenship. We need to focus on HIV literacy and education that incorporate evidence to form stigma reduction in diverse public communities. Each specific community needs up-to-date information to prevent ongoing stigma and trauma. Service providers must also engage in multi-level stigma reduction interventions at organizational, community, and societal levels. So from phase 1, we see the potential for collaboration with settlement service agencies to provide more information and secure resources for collaborative efforts. So this approach aligns with the principle of nothing about us without us. So this emphasizes the vital role of peers in addressing stigma. By integrating individuals and communities living with and affected by HIV into our efforts, we can enhance awareness, promoting, we can enhance awareness and promote meaningful inclusion of people living with HIV.
We will now dive a little deeper into the ACE intervention. HIV stigma is a priority issue, as we've discussed, that negatively affects people living with HIV or vulnerable to HIV, especially in terms of accessing HIV and mental health care. The Project ACE intervention program centers the ACE model, developed based on acceptance and commitment therapy, or ACT, and social justice-based group empowerment psychoeducation, GEP, to enhance psychological resilience and collective empowerment amongst participants. It consists of evidence-based trainings underpinned by the ACE model and reducing stigma at the individual and collective levels. The program consists of 6 online interactive self-guided modules, complemented by 6 weekly 90-minute facilitator group sessions. Our project at this time is carried out in 6 local sites across Canada, in the provinces of Alberta and Ontario, within the cities of Calgary, Edmonton, the Greater Toronto Area, London, Niagara, and Ottawa.
In this short video, we are going to provide an introduction to the acceptance and commitment to empowerment model. It is also known as the ACE model. What is the ACE model? It is a model that is grounded in 2 evidence-based approaches. One is the acceptance and commitment therapy. Another one is the group empowerment and mobilization. As you can see in this diagram, ACT can support us to develop psychological flexibility. That helps us to reduce stigma. On the other hand, GEM can help us to reduce stigma, and in addition, it gives us the skills and capacity to engage in HIV activism, as well as community mobilization to advance social justice and health equity. The acceptance and commitment therapy is a mindfulness-based approach that helps to increase psychological flexibility. That means that we are better able to face difficult thoughts and feelings, better able to choose our life directions based on our values, and become committed to these values through our action. We will briefly introduce the 6 ACT skills and processes that we will be practicing together throughout the training. Diffusion. Diffusion is our ability to observe our thoughts. Recognize that our thoughts are thoughts, nothing more, nothing less. It's also our ability to observe and let go of our thoughts rather than being hooked by them or getting stuck in them. Acceptance. It is about our willingness to face and experience thoughts and feelings, whether those thoughts and feelings are pleasant or unpleasant, difficult or neutral. It is also about our willingness not to run away from thoughts or feelings or trying to control them or fighting with them. Present moment is another processed skill. It is our capacity to be in contact with the present moment, our capacity to fully experience the here and now. We can do this through mindfulness practice. Self as context. Self as context is about our ability to be in contact with our observer self. That means we're able to notice and observe our self-concept, our labels, our stories, our experiences. It's also about being able to recognize that none of these things define us. We're not our labels or stories or experiences. It is about knowing that we are the holder that contains these experiences. We are not our experiences. We do not need to be trapped by the labels and stories about us. Values. It is about our ability to be in touch with who and what matters to us the most in our lives. Our values gives us a sense of direction and deep meaning in life. Last but not least, committed action. It is about our ability to align our action in the direction of our values and deep meaning in our lives. It is about being consistent and persistent in our action, even when we are faced with challenges and difficulties. As you can see here, all the 6 skills and processes of ACT can support us to develop psychological flexibility. In addition, they are all interconnected and linked. Therefore, if we practice and increase our skills in one of the skills, we are better able to also strengthen our other skills in other processes. So that mindfulness, being in contact with the present moment, will enable me to diffuse from labels and stories that is really not me. I'm better able to become the observer of my experiences and labels and stories, and being able to commit to what's important to me, accepting that sometimes the feelings could be painful, but sometimes the feelings could be joyful. All this together will enable me to stick to what is really important to me and take action about it, even when there are difficulties and challenges that I have to face with. As we shared earlier, ACT plus GEM is what we come out with the AIDS model. So then what is GEM? Group empowerment and mobilization is the approach that promotes our ability to take care of ourselves and our communities, especially when we gain a deeper understanding about the broader health equity and social justice issues. GEM helps us to gain insight into how social structures and public policies affect our health and well-being. It enables us to recognize that we are interdependent and interconnected. It also supports us to work together to promote social justice, challenge stigma and discrimination, and promote our collective resilience. The 4 GEM principles and values include social justice and equity, empathy and compassion, interdependence, and our collective empowerment. The 4 GEM values and principles are connected by 4 GEM skills and processes. They include experiential learning, collaborative learning, critical reflection, as well as critical dialogue. So in the AIDS model, all the 6 ACT processes and the 4 GEM processes and skills are really important, and they are really connected, and together they work towards empowering all of us. Here you can see the diagram of how these work together. Through diffusion and understanding of self as context, we recognize that we are interdependent. When we practice mindfulness and we're able to actually connect to the here and now in our interaction with others in the community or another person, we'll truly be able to connect it to empathy and compassion. In addition, our understanding of social justice and equity, diffusing from rules that actually don't work, accepting that there might be challenging feelings, but when we connect to our values, then we're able to actually engage in committed action that would lead to our collective empowerment.
Phase 2 aims to engage and build capacity amongst existing service providers and community leaders, both living with HIV and not living with HIV, in the HIV and related sectors, such as the mental health sector, addiction sector, sexual health sector, etc., and apply a train-the-trainer capacity building approach. Service providers and community leaders engage in the 6-week program and receive a certificate of completion once they graduate. Engaging and training service providers and community leaders in this way equips them with the skills to improve their psychological flexibility on an individual level and empowers them to mobilize this knowledge at the collective level within their communities. The objective of this phase is to implement and evaluate the effectiveness of ACE in reducing stigma by engaging service providers and community leaders and motivating ACE graduates to become facilitators to train service users and members of affected communities. As such, the graduates of Phase 2 become facilitators in Phase 3, successfully building capacity within themselves and then their community members that they serve. As participants progress through the program, they are invited to identify and reflect on their values. This exercise falls after participants have engaged with mindfulness, diffusion, acceptance, and self as context, allowing them to practice the combination of these tools as they reflect on what guides their actions. Values here are defined as chosen life directions, like a compass, and not goals that one can achieve. They serve to remind us what we value and motivate us to commit to actions which fulfill these values. While values are not goals, they help us set and guide our goals. And when we go off course, they redirect us towards our goals. They help us remember that we can use different value-consistent strategies to achieve the same goals. That value-guided action on a personal level empowers us on a collective level. And being clear about our values enables us to see possibilities and alternatives to shared goals. In one of the exercises, participants are asked to reflect on whether they take actions based on the values that they uphold. This pie of life encapsulates major areas of actions for individuals, wherein consistency amongst values and actions would result in a higher number and discrepancy would result in a lower number. Such exercises allowed participants to really hone in on their values and identify what drives them and their actions. Ultimately, it allows a visual representation of values and associated actions for participants, inviting them to align their future actions with what they value. Identifying values allows participants to orient themselves and their chosen actions in alignment with what they believe would enrich their lives. The key goal here really is to improve the psychological flexibility of individuals and build capacity to maintain resilience in the face of stigma and empower others to do the same. As HIV stigma intersects with other forms of stigmas and discrimination, such as racism, sexism, homophobia, and transphobia, etc., the ACE model remains a flexible intervention to be adapted and implemented across various sectors. As such, Phase 3 mobilizes ACE intervention champions to implement HIV and STBBI stigma reduction activities within their own communities, building capacity within themselves, and empowering the same within their communities. Overall, Project ACE provides a capacity building and collective empowerment model, which begins with the contextual assessment and adaptation of our intervention, followed by implementing a train-the-trainer approach for skills and knowledge transfer to service providers and community leaders, and spread and sustained by the mobilization of ACE community champions who are trained service users and community members, trained by service providers and community leaders across sectors. In conclusion, the ACE intervention underpinned by the ACE model allows us to empower communities through value-guided community actions and maintain sustainable impact and long-term change. Empowering communities through the ACE model allows the ACE model to effectively empower communities by building their capacity to address HIV stigma. Through education, skill development, and resource mobilization, communities become equipped to take proactive steps in reducing stigma and supporting individuals affected by HIV. Secondly, value-guided community actions. By aligning community actions with core values such as empathy, respect, and inclusivity, the ACE model fosters a supportive environment. This value-guided approach not only helps in dismantling stigma, but also promotes holistic well-being and acceptance of individuals living with HIV. Finally, the sustainable impact and long-term change. Implementing the ACE model facilitates sustainable long-term change by embedding anti-stigma practices into the community fabric. Continuous community engagement and reinforcement of positive values ensures that the efforts to reduce HIV stigma are enduring and impactful. Thank you so much for joining our session today, and we hope that you were able to learn from our findings and participants just as much as we have been able to learn from our communities. Thank you.